I appreciate the opportunity to speak in front of you today. The mayor and the council members and women, I'd like to congratulate you on your recent elections and appreciate that. Look forward to continuing to work with the county and city leadership. Mayor, thank you for allowing Hendrick to kind of give a state of the union, if you will, as far as hospitalizations go. What I can tell you is the hospital between Hendrick Medical Center Main and Hendrick Medical Center South, formerly Abilene Regional Medical Center, has approximately 50 COVID-19 positives in it. The challenge isn't, are we at the 15% threshold as defined by what they refer to as TSAD. It actually is a limited ICU capacity for the hospitals. Pre-COVID, Hendrick Medical Center was at or near capacity in the ICU, where the critically ill need care. That is why Hendrick Medical Center looked to either build or purchase additional hospitals, and we chose to buy additional hospitals to reduce the fragmentation, coordinate care in the community. We have seen the success of that already, sharing staff, sharing physicians, sharing strategies, therapeutics, as well as transferring patients between organizations to maximize the care experience. We're seeing the benefits of that. But when Hendrick Medical Center purchased a couple of these hospitals, they had empty ICU beds. They had equipment, but they had no staff. Although Hendrick Medical Center was at 100% capacity, some of these other institutions were not. So we have a plan to increase ICU capacity immediately that was not otherwise available a week ago. The TSA data that we reference demonstrates undeniably that we have one ICU bed in this 22 county location. That is the entire 22 counties around us, and we are referenced as TSAD. That one bed is in Rolling Plains. Our ICUs are full. It's undeniable. It's not political. That's a statistic that you can go out and find. You hear about Amarillo, El Paso, and Lubbock, that they've exceeded their threshold, which is true. And they have more ICU beds than we have here in Abilene. We are the lowest ICU bed capacity of any of the TSAs in Texas. We have an issue. We had a problem before. It has been amplified post-pandemic or post-third surge. Our concern at Hendrick is the first surge was mitigated. It went down because we shut the economy down. No one wants that, but it worked. The second rise around the July 4th weekend, we went back down because of the mask mandate, and it went down. The question is, what is going to stop the third one? The trend is not our friend. Over 100 net positives are what we're experiencing here recently. I don't have all the answers, and the data is going to show you that there is no magic bullet as far as what we're going to do to fix it. We know what fixes it, but the pain can't be worse than, the cure can't be worse than I forget. You know what I'm saying. So the point of that is we're not trying to do that, but we're going to have to lean on everybody in this community to figure out their control that they can control. Control the controllables. I can't control what the school does. I can't control what bars do. I can't control any of that. My job is to report the facts to you. ICU capacity is at a limitation. I'd like to invite Susie Castle, our Chief Nursing Officer, and Dr. Lowry, our Chief of Staff, to come up here and briefly touch on what we are doing to expand ICU capacity in the short term, because Hendrick Health will have to have long-term plans as well.
Thank you, Brad. I'm Stephen Lowry. I'm currently the Chief of Staff at Hendrick Medical Center, and as Mr. Holland said, ICU is our real issue here. With regard to caring for the patients that are coming into our hospital. It's been an issue for a while, and an issue that we have a game plan for long term that he just outlined. But on the immediate term, in the short term, I'd just like to give you some information, some details. We've got 24 ICU beds at the main campus. There are 16 beds at the south, but as he mentioned, staffing those beds is an issue. Nursing staff, respiratory therapy, the folks that are required to actually care for the patients is one limiting factor in us expanding our capabilities. When you look at the trends locally, about 5%, 4 to 6% of the positive cases, positive tests end up needing hospitalization. And of those, probably about 10% or so end up going to the ICU. You can do the math and you can watch as our total positive tests climb, you can predict how many ICU beds we're going to need, how many hospital beds we're going to need. And we've got contingency plans that we go through on a daily basis. We try to look on a rolling 3-day period for scheduled procedures that would require critical care, post-surgery, cath, whatever the procedure is, and anticipate just the day-to-day things that we normally see, admissions requiring ICU, predict that, and then factor in on top where we see the trend going and try to figure out what's tomorrow going to require of us. So we fluctuate our contingency plans based on that data as best we can, and we're actually getting better and better. We've been doing it since March, and I'd like to think our team's gotten really good at trying to predict and surge, compensate for the surges. Where we're getting right now in our trend, though, is concerning, because if it continues without something to bend that curve back down, we potentially start impacting other things. As you surge into areas that have space, if that continues, things like elective procedures or other service lines are going to be impacted potentially. And that's one thing that we definitely want to avoid. We've got an immediate staffing relief, I guess, would be, which I guess I'll let you address. But and that will help, but we've got to bend this curve down with the involvement of all of our community members and get things under control so that we can continue to care for the day-to-day stuff as well as the COVID patients. When I say elective, it's things that people wouldn't necessarily consider elective. Things that we do every day, but that general public wouldn't consider a routine procedure, such as a bypass for coronary artery disease, a craniotomy for a tumor or some type of intracranial process, things that are big surgeries that require an ICU bed post-operatively. And when we don't have the bed, we end up shuffling, arranging, going through our contingencies to try to make space. And if we can't make space, that gets put off and delayed.
Thank you, and thanks for the opportunity for Hendrick to get to come and speak. As Dr. Lowry mentioned, contingency plans go through many, many steps, and we overflow. And as Brad mentioned, we didn't have enough ICU beds, so we purchased some more. They're not staffed. But every day inside the hospital, it's almost like a puzzle. We've got this many patients that need this kind of procedure, and how critical that procedure is so that we don't have to postpone it or reschedule it. So that the nurse leaders there go through that every day with physician leader help and getting physician input on those procedures. The second thing is we have, requested some staff, nurses from the state. And we got word yesterday that we're receiving some of those, some arriving as early as today and tomorrow. And when we request that, it's things like ICU staff, things like respiratory therapy, and then also some telemetry nurses too. So that helps us with our new expanded capacity at the other facilities to be able to open up space capacity that we had. We just didn't have the nurses or the staff to go with it. So we're very pleased about that.
Thank you. I'd like Dr. Binkley to come up and briefly talk about the therapeutics and service offerings at the hospital. In the meantime, I want to put an exclamation point on what our Chief Nursing Officer, Susie Castle, just said. We had to request labor from the state of Texas to come help us here in Abilene, Texas. The state has identified the lack of ICU beds regardless of the 15% TSA threshold, because the TSA threshold isn't really applicable to the experience that we see here in West Texas, because it includes beds like a behavioral health, Oceans, it includes rehab beds, and hospital beds in the rural communities that do not treat COVID patients. So the TSA number is not what we focus on. We focus on ICU beds. Dr. Binkley, would you update everyone on therapeutics and service offerings?
Absolutely, Brad. Thank you very much. My name is Gary Binkley. I'm the Vice Chief of Staff at Hendrick Medical Center. I am an internist as well. The therapeutics for any viral illness is largely supportive. As with COVID, obviously there's a lot of research pouring into that, into the management of COVID-19. It's largely oxygen and steroids are the mainstay treatments. You support patients through other illnesses that they may have, such as diabetes, kidney failure, etc. We do have other therapeutics available that are currently being studied. A lot of these studies are preliminary on whether or not these therapeutics actually work. Again, we do offer these therapies. We meet routinely. I have a COVID subcommittee that meets very frequently to discuss any new data and therapeutics that are available. There's a couple of trials that we're involved in. But again, the mainstay treatment at this point is still supportive. Obviously, a subset of the COVID patients that are on our regular wards do end up in the ICU, which is where the bottleneck occurs. And those patients tend to get very, very ill. They tend to be on ventilators for a very prolonged period of time. So when we have 10 patients in the ICU, for instance, it's not that those patients are going to be gone in 3 or 4 days. They may be there 3 or 4 weeks. And so the turnover there is very, very slow. And so as you add 1 or 2 patients, you really get into trouble because they're predicted to be there for quite a while. Again, in those scenarios, it typically goes from a viral pneumonia to a more of a pulmonary edema syndrome that requires a prolonged period of time to recover from. And it is largely supportive. We don't have a good therapeutic to mitigate that in all cases. And so the mask wearing, as an internist, I like to focus on prevention strategy. We do not want to shut down the community or the bars and restaurants, but we do ask that we bend this curve a little bit through mask wearing. That has been proven to work, and slow the spread of the virus so we can treat these patients appropriately.
Thank you, Dr. Binkley. And I'll just close by saying that, again, it goes back to the trend is not our friend. And we know what fixed the first wave. We know what fixed the second wave. And we just request, recognizing that at this point it feels like we're waiting on the vaccine, we don't anticipate that that's going to be next week. What are we going to do to fix this trend? It is not just an Abilene issue. It's a statewide issue. It's a national issue. We've explained our limitations, and we really just are making a plea for help to the community to control your own controllables. And with that said, I'd like to thank the county as well as the court here, and y'all have a difficult job, and we're not elected officials, and we recognize the balance, and we just appreciate the opportunity to speak today. Thank you.
I want to thank you, and the community should know